Good evening, everyone, and I hope you're enjoying your dinner. And I think I can speak on behalf of all of us in saying thank you to the organizers for a really superb afternoon. And we heard many, many provocative comments today, and I think our heads are reeling with all this information that we received, some spanning from public health to psychology to art to feminist studies. And our tonight's speaker will put all of it together for us and really give us a framework upon which to understand body image and its roles in our personal lives as well as in society and in our larger culture. So I am truly delighted to introduce tonight's keynote speaker, Abigail Saguy, who is Associate Professor and Vice Chair of Sociology and Associate Professor of Gender Studies at UCLA. She's a fellow sociologist. I just remembered I was supposed to introduce myself. So I'm Debbie Carr, Chair of the Sociology Department here, which makes me all the more delighted to introduce a fellow sociologist. Professor Segi received a PhD from Princeton University and from the École des Hautes Études en Sciences Sociales from Paris. She was a Robert Wood Johnson Scholar in Health Policy Research from 2000 to 2002 and a fellow at the Center for Advanced Studies in the Behavioral Sciences at Stanford University, both of which extremely prestigious fellowships. She's the author of her first book, which you won't hear about tonight, but really sets the stage for her second book and its approach to studying social problems. Her first book was entitled What is Sexual Harassment? From Capitol Hill to the Sorbonne, published by University of California Press in 2003. And her latest book, which you'll hear about tonight, is called What's Wrong with Fat? And it's a really fascinating cultural and sociological look, not at kind of why some people are fat or not, but why as a society do we care so much, and why are these messages so powerful in our daily lives? And the book, What's Wrong with Fat, is just one of her many contributions to the social sciences. She has also authored over 20 scientific articles, which have appeared in really the most prestigious journals in our field, including American Sociological Review, Social Problems, Law and Society Review, Social Psych Quarterly, and a host of other journals. Professor Seguy's work is often featured in the mass media, and her most recent book alone has received tremendous press, ranging from Washington Post to LA Times to Huffington Post to USA Today. Really, whenever I see an article these days about weight, it somehow features the work or commentary of Professor Saguy. So tonight, not only will you hear her talk about the book and really contextualizing the day's events, but you'll also have the opportunity to meet the author and purchase her book over at the book signing table after the presentation tonight. So please join me in offering a warm welcome to Professor Abigail Saguy.
Thank you, Debbie, for that very generous introduction. It's a pleasure to be with you here today. I really did enjoy this afternoon's panels. They were super interesting, and I know that some of you have found that there were a lot of different kinds of messages. Some are feeling a little confused, and I'm hoping to, as Debbie said, give you a little perspective from which to think about my book, What's Wrong with Fat, is really about how and why we talk about body size in the way we do. And so I think we've had just now a lot of examples of some of the ways we talk about body size. And so I want to help you make sense of those. I'd also like to thank the Rutgers Institute for Women's Leadership for inviting me, and specifically to Gloria Backman, Alyssa Bernstein, and Lisa Hetfield, and to Gail Riley, I don't know where she is, but who has been, for all of the details in making this conference work and for facilitating my presence here today. So my book, What's Wrong with Fat, marked the culmination of 11 years of research examining how and why obesity, and I do put this in quotes, I'll tell you a bit why I do that in a moment, has come to be defined as a major public health crisis. So this work is, I think of it as within a larger tradition of feminist research, which has interrogated the tyranny of slenderness. And yet that broader work, if you think of Susan Bordeaux's work or Naomi Wolf's work, has focused on fashion industry, right? And thinking of that as the culprit of telling women that they have to fit a certain image and that women can never be thin enough. Where I focus is on the medical and public health establishments. And I also look at the extent to which they are being influenced by and in cooperation with the pharmaceutical industries, and how this is also contributing to the pathologizing of bigger bodies. And this is really important, I think, because as influential as media messages are, Cosmopolitan, I know that we're talking about Cosmopolitan magazine. These fashion magazines are very influential. But I think it's different when you are told that you're not fashionable enough and that you're not cool enough if you don't fit a certain image than if you're told by your doctor, or if you're bombarded with messages that this is a health problem and you are going to die if you don't weigh a certain amount. And so it's really upping the ante, and I think it's important for us to discuss and think about it. Now, you may think, I mean, on its surface, the talk of the obesity epidemic is gender neutral. This isn't targeting women specifically. And yet, it is occurring in a social context where women are more likely than men to be judged on their appearance, where they are more likely to diet. They are the greatest consumers of weight loss products and weight loss drugs and bariatric surgery. Women are also more likely than men to suffer from weight-based discrimination. And yet, as I show in my work, this talk of an obesity epidemic has gone far to stymie efforts to advance fat acceptance, which would be drawing attention to the problem of weight-based discrimination. So what's wrong with fat also draws attention to an understudied aspect of diversity and basis for discrimination, which is body size, while showing how body size and weight-based discrimination intersects with other forms of social status, such as gender, race, sexuality, and social class. So in my words to you this evening, I'm not going to be talking about what you should eat or how you should live. Instead, what I am going to be doing is encouraging you to think critically about the information that we receive on a constant basis about these things, about health, weight, nutrition. And I'm going to be offering you some perspective to think about what's not said, the taken for granted. And one of the things that is taken for granted, I mean, when we talk about weight, we often talk about obesity, right? We use this word, obesity, as if it's a thing. Obesity, overweight, these are things we have to deal with. And then we can ask, well, why? What has caused this obesity epidemic? What should we do about it? Is BMI the best indicator, or is there some better indicator? What I would like to suggest to you is that this term obesity is part of a frame. It's implying a certain way of understanding body fat, a way of understanding bigger bodies as diseased, as a medical problem, and increasingly as a public health crisis. So if I were to talk to you and say, are you pro-life? You would know that this word pro-life was part of a certain frame. Right? It's different to ask, are you pro-life, are you pro-choice? Those two terms are not neutral, right? Each of them is implying a certain way of understanding abortion. If I use the word pro-life, then that is implying that abortion is murder. If I use pro-choice, that implies that abortion is about a woman's bodily autonomy. Very different frames. What you probably don't realize is that when you use the term obesity, you are also invoking a frame. That implies that body weight, independent of anything that might be related to it, nutrition, exercise, social status, body weight is in of itself at a certain point, no matter how we want to define this, we do define it as BMI, that's the most common way of defining it, but that after a certain threshold, it becomes a disease. And at a population scale, it becomes a public health crisis. So it's not a neutral term. And I want to interrogate this term and think specifically about this medical and public health crisis, these frames, and show you So a lot of my work, Debbie Carr said, you might not have seen the connection between my earlier work on sexual harassment. What does sexual harassment have to do with body weight? But the connection is that in both of these works, I'm talking about framing. So without getting too much into the work on sexual harassment, my work on body weight is interrogating these frames. And so what is a frame? A frame you can think of as a picture frame. Is a way of drawing your attention. So we had artists, right? Artists work with frames. But in social life, too, we need to frame things. Part of this is cognitive. If we couldn't get out of bed without simplifying, making sense of, focusing on certain aspects of reality and not others, right? Otherwise, we'd be overwhelmed with the buzzing, blooming confusion of it all, to cite William James. So these frames are cognitive. They simplify. And they draw attention to certain aspects of reality while they obscure others. I'm not saying this is a bad thing. We have to do this. But there are social implications. Frames are also political. When we talk about frames as political, we also often talk about them as spin, political spin. But that's another framing. What are we going to focus on? What are we going to emphasize? And frames have both a diagnostic function and a prognostic function. So what is going on here and what should be done? So in my book, I talk about 6 different frames of fat as a problem, and I also talk about 3 different blame, and among those 3 are why this is a problem and 3 are why this is not a problem. I also talk about blame frames, different ways of assigning blame and responsibility. With you today, I'm going to focus on 3 problem frames. I'm going to set the blame frames to the side for the moment. And we're going to talk about 2 frames, the most dominant ones, which I've already alluded to, the medical frame and the public health crisis frame. I'm going to tell you about what those frames bring to light, what aspects of reality they showcase. I'm not saying they're completely wrong. There are aspects that they capture. But what do they obscure? And then we're going to talk about another frame that you may know less about, which I call the fat rights frame, which thinks about the problem in very different ways and has very different implications for what should be done about it. So I'm not going to tell you too much about how I know what I know, my data and methods. I can answer that in the Q&A, but this was based on 11 years of research, including interviews, content analysis, experiments, and a lot of reading of scientific literature and participant observation. Okay, so let's begin talking about this medical frame. So this is really what is being implied when you hear obesity. The medical frame you can trace back to the mid-20th century when we started talking about weight as a medical problem. Earlier in the century, it became seen as unfashionable, and before that, there was different. We were talking earlier about the ads that you can find at the turn of the 20th century that were for weight gain. You know, you don't need to be a thin woman who can't attract men. You can gain weight with this product, and you see a lot of these at the turn of the century. So it falls out of fashion before it becomes a medical problem, and doctors really, around the 1950s, organize, they create journals, they create associations of bariatric medicine to say weight is a medical problem. And they use the term obesity. This was a very strategic and self-conscious act of the medical establishment to use a term that would evoke medical expertise and to distinguish it from the other ways of thinking about weight as, corpulence or plump or other things, Rubenesque, that had non-medical terminology. Okay, so this medical frame, what is wrong based on the medical frame? Well, it's in clinical perspective, an individual perspective, that excess weight on a person or fat, there can be some variation, is a medical problem. What should be done? The person should lose weight. And this is drawing on the master frame of health. And each frame also draws on different analogies. The analogy that I found in doing interviews, so I interviewed some of the leading obesity researchers for my book, and they drew analogies to cancer. This came out particularly when I asked them whether they would recommend bariatric surgery for a loved one, given all that we know about the risks associated with bariatric surgery. And they said to me, yes, I know, or weight loss diets for that matter. We know 95% of people who lose weight gain it back and often gain back more. So do you want to really recommend this treatment for someone you love? And what they said is, well, it's like cancer. I know that cancer is a killer. If we do nothing, the person's going to die of cancer. It's the same with obesity. Yes, the solutions we have don't work very well. Yes, there's complications associated, but I know that we need to do something. It's like cancer. Okay, so that analogy then makes this frame seem natural. It makes it seem like it makes sense. Well, the medicalization of fat is part of a larger phenomenon that medical sociologists have documented called medical expansion, in which larger areas of social life have come under the purview of medical expertise. We see this with pregnancy, which, used to be something that women did on their at home with midwives, etc. There was also higher rates of mortality, so there's some advantages of medicalization, but it becomes highly medicalized. We see this with menopause, right? It used to be a fact of aging, or erectile dysfunction, if we want to give men a fair shot, right? Something that was a normal part of aging becomes a medical problem, a disease that can be treated. Now, this happens especially when there are scientific and technical innovations that can be proposed to solve the problem. There's no point in creating a medical diagnosis if we have nothing to offer. But if we have something to offer, then there is more of a motivation. And this doesn't have to be a mean-spirited thing or trying to take advantage of people, but if you can't help them, then there's no point in drawing attention to a medical problem. And if you feel that you do have something that can help, whether it's medication for ADHD or hormones for menopause or Viagra for erectile dysfunction, then there's more, it makes more sense to make this a medical problem. And so in the middle of the 20th century, the big, so if I had my PowerPoint, I normally do this with a PowerPoint, I would show you this image of a smile and wires on the top. And I'd ask you if you knew what that was. And some of you might recognize it as jaw wiring. So this was the technological innovation of the mid-20th century. It worked for the time that your jaw was wired shut. People lost weight because they couldn't open their mouth and eat, and so they only drank liquids. And people do lose weight when they only drink liquids short term. They gain it back once the wirings come off, and they have to eventually come off. So that may seem barbaric, but it's not all that different from the technological innovation of our time, which is bariatric surgery. Bariatric surgery is not correcting a faulty stomach, it's making it hard to consume large quantities of food. It's a physically enforced diet, much like the jaw wiring was. And so, yes, there's also short-term, there's weight loss. It's hard to know long-term what happens because the surgery is always changing. And so as soon as you get out a certain number of years and want to look back, it's, lo and behold, it's not the same surgery, so you need to start again. Pharmaceutical deregulation and expansion that begins in the 80s and has continued, this direct consumer marketing has really contributed to medicalization, medical expansion in a wide range of issues, including that of weight. I mean, the pharmaceutical industry is a $300 billion a year industry, and so they have an enormous amount of influence and have also in this area via the International Obesity Task Force. So there was some talk earlier about the change that happened circa 1997, 1998 with the NIH guidelines defining the cutoff for overweight down from 27 and change to 25. And what wasn't mentioned is that that report was authored by the International Obesity Task Force, which receives funding from Roche Pharmaceuticals. And that same report became the 2000 World Health Organization report. And so these are some of the things that are also important to understand in terms of how it is that we've come to think about larger bodies as a medical crisis and a public health crisis. So the medical frame, I'm not standing here to say there's absolutely no association with higher weight and negative health implications. There are some, and the medical frame highlights these. So let me just say, what I think it highlights that is correct. So higher BMI is clearly correlated with higher likelihood of developing type 2 diabetes. That's actually a linear correlation. You don't have to get past a BMI of 25 or 30 for it to happen. It happens even within, the correlation is linear, even within the normal weight category. Now, it's a correlation, it's an association. We actually don't know whether heavier weight or fat per se causes type 2 diabetes. That's one possibility. Another possibility is that insulin resistance causes weight gain. A third possibility is that some third factor, diet, nutrition, exercise, stress, host of things could be causing both. But the association is there. There's also people who have a higher BMI, people who are in the obese categories, BMI of over 30, are more likely to die of heart disease than those who have a lower BMI. And rate of all-cause mortality is higher in those with a BMI of over 35. So these correlations are there, and they're highlighted by the medical frame. But the medical frame also misses some important things. So for instance, we've spoke about in a few panels that the group at lowest risk of mortality is the so-called overweight category. This overweight category, BMI of 25 to 30, is least likely to die of all causes. And overweight is often lumped with obesity as this is the big problem, right? Overweight and obesity. There's also, we talked that there was a little reference to the obesity paradox. I just want to say a little bit about that. The obesity paradox is a large and growing area of research that shows that among clinical populations, including and especially among those populations like heart disease and type 2 diabetes, for which heavier people are at greater risk of developing. But if you look at the clinical population, those people who already have those illnesses, the people in the obese category are less likely to die than the normal weight. It's called a paradox because it's paradoxical if we adhere to a medical framing of fat in which bigger bodies, heavier bodies are inherently pathological. It wouldn't be necessarily such a paradox if we nuanced our thinking about weight a bit more. So the medical frame misses a lot. For where we see the highest association, which is, you could talk more broadly, is this large category of cardiometabolic profile. So there's a study published in 2008 that looked at cardiometabolic profile. So these are things like blood pressure, bad levels of bad cholesterol, sugar level, etc. And looked at the correlation between the different BMI categories and abnormal cardiometabolic profile. And so there's clearly a correlation, right? And I'm not going to deny that. So for instance, if you were, people in the normal weight category, 24% had an abnormal cardiometabolic profile, but that it goes up when you go to overweight, 49%, and even higher for obese, 68%. So the correlation is there. The problem is, if we think about obesity as itself a disease, or if we equate bad, abnormal cardiometabolic profile with obese, then we're missing a lot. What are we missing? We're missing 16 million Americans who are in the so-called healthy weight or normal weight category who have abnormal cardiometabolic profiles and may be undertreated. And we're also perhaps over-treating or thinking, we were talking, some people said, well, you don't know what my health is by looking at me. Well, yes, with people in the overweight category, over half of them have normal cardiometabolic profile. Almost a third of those in the obese category, or 20 million Americans, 56 million if you add up the overweight and obese category, who will have a completely normal cardiometabolic profile and yet are assumed not to be. So this can also lead to medical error and overtreatment, undertreatment, if we're using BMI as a shorthand for health. I think this is very dangerous. So I just spoke about the medical framing. I see this as different but related to the public health crisis framing. So up until about the mid-90s, obesity, weight, here I'm using the term obesity because that's the term that would be used, was seen as a medical problem. But it's only really in the late 1990s, actually just before I started doing my research on this, when I was at Yale with the Robert Wood Johnson Foundation as a health policy research scholar, I started doing this research because some of my colleagues who are political scientists were saying, why isn't this on the public agenda? Why isn't anyone talking about obesity? Well, things changed very quickly, but this is right where it was changing. And so in the late 90s, early 2000s, people start talking about weight, obesity, not just as a medical problem, a clinical problem for an individual, but as a public health crisis. And so here, the issue is that as a population, we're getting heavier. And this is this is both a health concern and an economic concern. It's going to bankrupt the healthcare system. And this is where we also see the talk of epidemic. And so that earlier report authored by the International Obesity Task Force, it uses this term global epidemic, which becomes the 2000 World Health Organization report. If you look at the earlier World Health Organization report published before the International Obesity Task Force existed, they had a very different take on obesity and didn't think that we should be using BMI to begin with to diagnose obesity because it wasn't picking up fat, which they thought was important, and there wasn't this talk of a global epidemic. So this happens later. And here, okay, this frame too picks up some things that are true. It is true that in the 70s, a little bit, in the 80s more, and in the 90s, population weights increased. And because so many people, the bulk of people, and the kind of the most people were just at that cutoff between that 25 mark, and also a lot of people at that 30 mark. Even small increases in average weight over this time caused large amounts of people to move over the threshold into the overweight and then also obese category. So there are increases in population weight that happened in the 80s and 90s. That part is true. I could note that they stabilized in the 2000s. All of the studies suggest this. But this part is true. It's also true that thanks to this 1998 decision that even more people started being counted as overweight because we also, as people are getting heavier, we also lowered the cutoff, right? So this also contributed to it. Incidentally, people have also gotten taller, at least since the Civil War area. So the average height of men at the Civil War time was 5'7", and today it's 5'9.5". So what Jane Brody said, we have actually, it's not true that we haven't gotten taller. We've also gotten taller, but we've also gotten heavier. So that part is true. The question is this a health problem? So the epidemic, this idea of a global epidemic, implies that moving from a BMI of 29 to 30 is like contracting a deadly disease. And I think I've already addressed that it's really much more complicated. And in some ways, having a BMI, you're protected. It's just not a clear, you don't automatically become unhealthy. So, okay, I'm going to pass over the rest. We can talk more about the epidemiology in the Q&A. I want to stay within my time because I'm really interested in the dialogue with you, and I want to get to the third frame, which I call the fat rights frame. So the fat rights frame really takes a completely different approach. So whereas for the public health crisis frame, the problem was as people were getting heavier. For the medical frame, the problem was that an individual was too heavy. According to the fat rights frame, the individual weight, population weight, is not the problem. The real problem is that there is rampant weight-based discrimination and stigma. So the solution then is not to get people to lose weight or to lose weight at a population level. It is to address this weight-based discrimination the same way that we've addressed other forms of bigotry in society. And so they're drawing on the master frame here of civil rights and also on other successful movements. And so I have in front of me, which if I had a PowerPoint you would see, this really neat button that says, "Fat by nature, proud by choice." So here, this button is clearly drawing on the gay rights movement, right, that has really challenged this idea that sexual orientation is a choice. Well, that has its own pitfalls we can maybe discuss, but this is what they're drawing on. So they're making a very different analogy. Rather than analyzing larger weight to a disease like cancer or an epidemic, they're drawing analogies to race, gender, sexual orientation, disability, and saying this is just like that, and we need to treat it like that. They're also not using the word obesity or overweight, which they recognize as invoking this medical frame. And with overweight, it's very normalizing. Over what weight, right? And instead, they're reclaiming the word fat rights movement, fat activism, fat acceptance. And here again, they're learning from earlier civil rights movements that have reclaimed black as beautiful, queer as something to be proud of. And so Joy Nash, who, if you're interested, I highly recommend when we're done with this, later this evening, going on YouTube and typing in "fat rant Joy Nash." It's very funny and very inspiring. She says in this video that went viral, "I'm fat and it's okay." So, it's not against this sort of tell me I'm not fat, I'm fat, oh no you're not, against this kind of fat talk. No, I'm fat and it's okay. It doesn't mean that I'm stupid or ugly or lazy or selfish. I'm fat, F-A-T, it's 3 little letters, what are you so afraid of? So reclaiming this word. And what does this frame draw? Well, I can first say, what does it downplay? Each frame draws attention to certain things and downplays others. This frame is clearly downplaying any of the health risks that all of the other ones are talking about. And instead, it's drawing attention to weight-based discrimination and fat shaming, which exists in employment, in education, in personal relationships, and even many studies suggest the worst place where anti-fat bias is most pronounced is in healthcare settings, which is, I think, very disturbing. And so, just a few, let me say just a little bit more about weight-based discrimination. Studies show that heavier women are less likely to be hired and earn less. Weight-based discrimination has been shown to be much more of an issue for women than for men. There's even a very disturbing study that shows that parents pay less for their education of their heavier daughters than for that of their thinner daughters. Heavy women are less likely to marry. When they do marry, their husbands earn less than the husbands of thinner women. And many surveys have shown that healthcare workers typically regard their heavier patients as lazy and non-compliant and to blame for whatever health care problems they are presenting, which is also why a lot of heavier women avoid healthcare, avoid the offices, and don't seek out the care that they need. One of these particularly is rates of cervical cancer are higher among heavier women, and heavier women are less likely to be getting pap smears. So, and when you ask them why, it's because they find the doctor's office a hostile environment. I talk before the Patient Protection and Affordable Care Act, morbid obesity was considered, so having a BMI of over 40, a pre-existing condition, and could be the basis of denying medical care. You can no longer do that, but the Patient Protection and Affordable Care Act does allow employers to charge their heavier patients more, their patients who fall into the obese categories, more than the normal weight patients, and that way treats it just like smoking. Except I would say that it's not a behavior. Weight is not a behavior, right? It's something that is related to behaviors, but in some way, but it's not simply a behavior, and there's other factors that determine it. And I talk in a Washington Post op-ed, I use this term size profiling to talk about the experience that a lot of people I interviewed told to me, and which is also documented in the larger literature, of people going to the doctor for sore throat, anything, any sort of thing, and the doctor saying, you know why you have this, it's because you're too heavy, or going in for one thing and being referred to the bariatric surgeon. And in some cases, these can be life or death, right, if they're not getting the medical treatments or tests to actually find out what's really wrong. And doctors are simply using prejudice and appearance to make diagnosis. Hopefully this is not what the best doctors are doing, but it is happening, and it's part of this broader context. We spoke about bullying, which is heavier kids are more targeted for bullying than our lighter kids. And women, there's also a phenomenon called hogging, in which heavier women are targeted for sexual victimization. Okay, so I think it's really important that we recognize that the medical frame and the unquestioned medical framing of this issue can really worsen and be used to justify this anti-fat stigma and discrimination, and that we need to be aware that it's happening so that we can counter it in the same way that there's been efforts to make us more aware of other biases that we hold in terms of gender and race. So I want to give you one example. It's disturbing, I'll warn you. It's from an interview in which a woman talks about seeing a new doctor. And it was an OBGYN, a woman. She came in. This was a woman who was active in the fat acceptance movement. And she said from the beginning, when the doctor started saying, your weight, and we should talk about your weight, she says, listen, my weight is not, I'm not discussing my weight. I'm happy with my weight. I want to talk about how I can improve, be healthy in other ways, but I don't want you telling me to lose weight. And she backed off until this woman had her feet in stirrups and she was having her gynecological exam, and I quote her. She says, the doctor waits till she puts the speculum in and decides to start telling me about, estrogen levels, and obesity leads to diabetes. And I'm like, okay, now I just told this woman that my weight is not up for discussion. I'm sitting here on the table, and what am I going to do? I think I went to a different place, because when I said, I can't believe this woman is actually doing this. And I can't jump off the table, because that's really what I wanted to do. So I just kind of went somewhere else. Okay, so this is really an experience of trauma happening in the medical context. And we could say this is a bad doctor, and better doctors would never do this, but it's also happening within a broader social context in which we're being told that weight per se is a medical problem, and that you're doing a woman a service. It's for her own good. And so I think as feminists, we've heard these talks about for her own good, and there's a large literature on this. We really need to be concerned about this. Okay, I'm going to say something to conclude with. In the last, or the 5th chapter of the book, I ask, what are the implications of this framing? So we've already spoke about some of the implications, what these frames do, and I think they really can have, the medical and public health crisis frames can have really negative consequences. One of the ways I tried to get at this with my research, and this research is ongoing, is through an experimental design, which I did with he was at the time a student in psychology, David Frederick. And so what we did is we had our participants, and we enrolled over 2,000 participants across different kinds of studies that varied in different ways, but I'm just going to give you the punchline. So the participants read one article. They were randomly assigned to read one article. Either they read a control article, which incidentally was by Jane Brody, although we took out her name and put the same male author for all of the studies. But it was it wasn't about weight at all. It was about cancer is overtaking heart disease as a leading cause of death. It had nothing to do with weight. That was the control, the neutral context. And then I'm just going to tell you about one of those studies. They could also read a study that was reporting on a 2004 study that has since been debunked, by the way, but that reported that there are 400,000 excess deaths associated with overweight and obesity every year. And it was a news article that was reporting on this, and it was also talking about people are eating themselves to death by eating chips and Coke and all of this stuff. And then we asked them some attitudinal questions, and I just want to highlight one. Compared to the control situation, so the neutral situation, those people who read that article, what I call the eating to death article, they expressed significantly higher rates of anti-fat prejudice in 4 out of 5 of our context. So they were asked about, do you think that fat people are lazy, shouldn't be hired, or are all sorts of measures of anti-fat prejudice, and they were more likely to agree with those negative anti-fat prejudice. And I think this is important because it suggests that all of this talk about the obesity epidemic in the media, and even in conferences, may be triggering not just senses of self-loathing or insecurity, but also making people feel more justified in expressing anti-fat prejudice. And I really think we need to be concerned about that. So just to wrap up with 2 final bullet points, I hope that in this talk today, I've convinced you that speaking about fatness or corpulence, larger bodies as obesity, which I hope you'll now see is a frame, it's not a neutral term, may have negative unintended consequences, especially for women who are the main consumers of weight loss products and suffer greatest from weight-based discrimination. And that to combat weight-based stigma and discrimination, it may be necessary to frame fat in different ways and also to talk about health in different ways. And so this is, I'm echoing what Sabrina said in her comments, we don't have to talk about weight when we're talking about the importance of nutrition or the importance of physical activity, which we know are important for our health. So at this point, I really welcome your comments. Thank you. Debbie, do you know that?
As we would think. Sorry. Hi. Yeah, I don't know of any studies that directly relate body mass index to suicide, and probably it's because in women, suicide is a rare enough event that in the surveys that also have data on body weight, it wouldn't be big enough to make it go. I also don't know any that look at suicidal ideation, but there is a link with depressed affect and lower levels of positive affect for kind of all the reasons that you just heard about: discrimination, poor quality social relationships due to kind of weight bias among members of the family network. But perhaps that's a study someone could do.
Thanks, Debbie.
I was just wondering, so what's the remedy? I mean, this is pretty profound, data that you, but I feel like, how is society really going to change?
How is society going to change?
Yeah, what is the remedy? What's the hope that that society will actually change?
Did you have a follow-up? Was that?
Hi, so my name is Prachi Bhavandkar, and I'm a first-year medical student right here, and here at Robert Wood. And I just wanted not to take away from your answer, but in terms of society changing, my mind, I feel like my eyes have been opened because I realized how much work has been done in the medical profession in order to give me the education I currently have, because we recently finished our GI and nutrition course in which we were taught how to talk to patients about nutrition and how to counsel them on what foods are considered healthy and what foods are not considered healthy, glycemic index, glycemic load. And we also did have seminars that taught us about fat bias and how not to make our patients feel unwelcome in our doctor's offices. So it is changing. I'm a first year. I can attest to that. Hopefully, so in the future, we'll have better doctors. But thank you, everyone, for all your hard work. That's what I really just wanted to say. Like, it is changing. So there's hope.
And I would add that it's not that the work that that's being done by medical professionals is very important, but this problem is much broader. And I think it takes all of us. I really do believe, as a sociologist, I think one of the things that sociologists can offer, that I offer to my students, is thinking critically, asking questions. And I think that, some people have talked about children and how you speak to children. And so I am also a mother, and I'm very careful and conscious of, I think we have to first interrogate our own biases and work those through so as not to reproduce them. And so not only do I not say, I think many parents would not say anything negative about their children's bodies, but also about my own body. So not to say, oh goodness, I should lose weight, or this is, or why did I eat that? But to convey positive messages. I think with our friends, we can be supportive and positive, and not engage in the fat talk, which is just rampant among women. So that, oh, does this make me look fat? No, you don't look fat. You look fabulous. Well, since why can't fat and fabulous go together? We're constantly reinforcing that. So I think to question these biases and is also really important.
So first, I got to respond immediately to, it was a little bit of to an aside or an off the cuff, but I mentioned trauma earlier because, for example, sure, parents say negative things, hurtful, painful, dehumanizing things to their heavier weight. You even stated some of that data just in terms of paying more for a college or not. And I'm talking about folks who probably don't have money to pay for their kids to go to college.
Absolutely.
So I just want to make sure, if we remember, Halle Berry got an Academy Award for being evil to her fat son, remember? Monsters Ball, but anyway.
Right.
But what I'm curious about is sort of a follow-up on that, on the question here, not only about the remedy, but about the sustainable social change. And it's sort of about how you frame the frames. And so let's take it that these three frames are all real and that they're tangible. But unlike the example frame that you gave, like pro-choice and pro-life, which I think there's yet to be a way to connect those two to get to the solution of whatever the problem is. I do think that then the three frames that you've identified, that somewhere in there, there's a way to connect those frames to actually get to a solution. So can you talk a little bit about that?
Thank you. So I do think that certain frames are more compatible and synergistic than others. And so certainly the public health crisis frame builds right off of the medical frame. I think, so there's another frame that I don't talk about in this talk, but I do in my book, which is the health at every size frame, which has been really advocated by clinicians and has been connected much more to the fat rights frame. And so there's a synergy. There's also the fat is beautiful frame is in practice, these things are, I'm pulling out these frames that I can clarify. This isn't an analytical tool that I'm doing. In reality, these things are much, much messier. So the health at every size frame is the idea that health is important, but you can be healthy at every size, and that we don't want to be focusing on weight per se, but focusing on things that people can control, such as nutrition, exercise. I think there's not as much emphasis in that as there should be on other important things like poverty and trauma and these other things that are out, that aren't so much behavioral choices. There are people who try to combine the fat rights frame with a medical frame. And so Kelly Brownell at the Rudd Institute has both a large research agenda. Rebecca Puhle is the lead author for a lot of that work and has done a lot of the work on her own, which is very important work in documenting weight-based discrimination. At the same time that the Rudd Institute talks about obesity as an epidemic, so that would be the public health crisis frame. So it's an epidemic, it's a problem, it's a medical problem, and yet there's this discrimination that we have to address. And so they're combining it. But the fat rights activists find that very offensive and take issue with that, because they say, how can you be talking about weight-based discrimination at the same time that you're reinforcing this discrimination by talking about our bodies as diseased and as an epidemic? So I don't know that that particular combining of frames is very successful. The bariatric surgeons also combine the fat rights frame with the medical frame. They say there's a huge problem of weight-based discrimination. You shouldn't have to suffer that. We'll help you. Come to us, have the surgery, and you'll no longer suffer. So we're offering a solution to this problem. And some would call that co-optation. So I think there are challenges. The health at every size frame really is still addressing health, is addressing many of the issues that a lot of people are concerned about in terms of that we've spoken about: access to nutrition, access to active lifestyles, inequalities, food deserts. But they're reframing it so that it's about health and not about weight.
Why is it so difficult to combine sort of fat rights in the medical?
Yes, and so thank you. So why is it that that it is difficult to combine them? So there is a lot of literature in sociology, the sociology of medicalization, that assumes that if an issue becomes a medical issue, then it will no longer be moralized. And so the big example is that of alcoholism. When it becomes a medical issue, it's no longer seen as an individual problem, but it's not their fault. It's a medical problem that's beyond their control. And yet, what's happening with weight is it's framed as a medical problem that, I mean, this came out actually in the Q&A in discussion to Jane Brody. You know, why is it not okay to be the weight I am? Well, because you're hurting yourself, and you're hurting the larger population. So what's going on there? Well, it's a medical problem on a clinical level and on a population level that is self-induced. And that's why there is both, there's still the blaming. Now, there's a lot of research showing that weight is much, you know, I mean, anyone will say this, any researcher will say, any careful study will say, of course, it's multifactorial, and we know that there's genetic factors. We now know more. There's also epigenetic factors. There's other biological factors that are beyond genetics or epigenetics. There are things that are beyond your control that have to do with things like trauma or environment, family situation, that are not biology, but nor are they the individual's control. One geneticist said that weight was as determined by genetics as height. This is Gina Collado discusses this in her book, Rethinking Thin, I think it's called. In my own work, one of the things I did is analyze news media reporting to get a sense of what the dominant perspective is, and the dominant discussion is of individual choices leading to weight gain. And for that, I think the case of smoking and lung cancer is similar. And I recently, both my father and my brother, neither of whom have smoked, recently were diagnosed with lung cancer. It was within the span of 2 months, and luckily it was stage 1 and it was removed. But I discovered from this that there's much less funding of lung cancer than there are of other cancers. And this has been explained in part because of the stigma associated with lung cancer, because it's seen as something that people bring on themselves, like weight.
You know, I really appreciate what you've done in the studies, and I think I may be coming from a little pessimistic perspective, but until there isn't a lot of money to be made in obesity, it's not really going to change, because right now, when you said the BMI went down and it was funded by a drug company, obesity makes a lot of money. So we can have a healthy weight at any weight or a healthy body at any weight, but that's not going to make a lot of money. You know, and it just seems to me this is a bigger issue than we're even talking about. Unless you get a couple of big drug companies behind that idea to help change, you know, it's
Yes, and
not popular now.
this is, I do talk in my book about the fact that this is not an even playing field, and those who are promoting the frame of public health crisis have much more economic resources, but also cultural authority that they can use to promote that message. They have a much bigger microphone, and those challenging it have a smaller one. Now, we did see images from the Dove campaign, right? So sometimes we get some pushback. Dove was selling lotions and soap. It was, I think, toning lotions, and as part of that campaign. And so those sorts of things are also there. There's some pushback, although that campaign has also been criticized for not going broad enough, not showing as diverse a range of bodies.
I was picking up on something you said. My question has to do with something that I've been thinking about for the whole conference, which is that a lot of these analyses have come out of very personal experiences, as well as looking more in terms of the academics of them, and some social service interventions have been used. It seems to me that the difficulty in in merging the frames is that at some point, the only way to handle the solutions to the problems are through public policy. And as people were speaking today, I was thinking, well, what would they say about what kind of public policy would be helpful in any of the particular orientations that were presented today? And so the issue of where do you find some synergies in the frames that might capture some attention? So I was thinking, well, maybe with children. It's always useful to start with children. People can get behind children. So, sort of thinking about maybe some of the possibilities of public policy based on some of your findings and what you think about that.
Thank you. Well, I think with children we have to be very, very careful. This is a very vulnerable group. They're already, heavier kids are already bullied. And I think when we tell children it's unhealthy to be fat, there's this word obesity, and it's referring to your fat peers and their disease. And we need to wipe out this disease. We need to wipe out childhood obesity in a generation. There's a real risk of reinforcing stigma and making the bullies feel like, well, they're justified. Again, it's for their own good. They weigh too much. They need to know that they shouldn't be eating that piece of pizza or wherever it is. They need to be shamed into changing, and the shaming we know doesn't work. It doesn't work for adults. It doesn't work for kids. If you feel ashamed about yourself, you don't take care of yourself. And this whole discussion of weight, not only as a medical problem, but as one that people bring on themselves, it is shaping policy. It's used to say, food stamps, should we really be giving these people, food stamps? They clearly don't need it. What they need is less food. And the issues of poverty and growing inequalities have only gotten worse. And I think the way we talk about obesity as a disease people bring on themselves is informing policy in a negative way. And so I would really like to see us talking about rights to access to, a lot of things that people are doing, whether it's Michelle Obama's campaign or whether it's, I'm forgetting her name now, but who was talking about the school lunches. These can be very positive things as long as they're not talked about as solutions to obesity, as ways of getting rid of a certain body type, which will always exist. But instead talking about people's rights to good, healthy food, and that this food is beneficial for kids of all sizes. And believe me, there are a lot of very thin kids, right, who eat crap and who don't exercise and who are lulled into complacency, perhaps as well, or aren't told that they should be thinking about nutrition. Thank you. Thank you.
You're fine.
We do.
perspective.
That's because everyone has a story, Abigail. That's truly, and I'm not just saying that as a phrase. Sister Love actually has an intervention. It's online. It's a video series called Everyone Has a Story. It's intentional. First of all, I just want to, again, hear from everyone a round of applause for an amazing all-day or afternoon and evening. I know we've said thank you to our partners and our sponsors earlier, but I also want to make sure that we give a hearty thank you to our organizing team with Lisa and just all of the folks from IWL and the other Institute partners. I want to thank all of our speakers because they all told amazing stories today, so give them another round of applause, please. And then look to your neighbor next to you and look him and her right in the eye and tell them thank you for being here today. And then give them an applause. If I didn't think it would disrupt my closing, I would tell you to go ahead and give it a hug, because every time you get a hug, you grow a T cell, so you have to do that when I'm done. So the first thing I do want to do is remind you that we do, for a little while following our closing, we have a book signing with Abigail. Is that going to be in this section over here, Lisa? Okay. So you can continue your conversation. Just two things I think I wanted to say, and I love it because Denise has been saying it all afternoon, is that I wanted to think that we've sort of followed a pattern of what we hope happens when we have events like this. And we started out very provocatively, quite frankly, and we had a little controversy, which ain't necessarily a bad thing. So we went from controversy to a little consciousness raising, and together those things lead us to making change happen. So I think that we're on the pathway to something different, and that all of the stories and that all of the perspectives and all the information and the conversation and the debate actually enrich us for getting to those changes. The other thing I want to acknowledge is the intersectionality of this conversation. We could have only heard from the science perspective. We could have only heard from the sociologist perspective. We could have only heard from the fats rights or the human rights or the social justice perspective, or we could have really enjoyed just in every piece of art that the artists have brought us. But we brought all of that together, and I think that that's exemplified through the panels that we had this afternoon, as well as the opening and closing keynotes. And the other side of that intersectionality, and this is what was coming from my question, is that all of the issues, all of the pieces that were brought together today, I think are a part of, I work in these principles of I's, and a lot of them have integration as one of them, intersectionality is another one. But I also think we've lifted up a lot of things about weight and image and just the lived experiences of women that are interconnected, that are interrelated, that are interdependent, and that's how our responses have to be to the problems that we define. So if I could, I would close on the way I started when I talked earlier, and that is, it really, really, really is important to acknowledge and own our own stories, and then be willing to share them, because those stories give experience to someone else that may or may not already be in touch with their own story. So this is something that I do with my positive women all the time, because I have this working mantra called "you did that." So anytime they already have a problem, when they're acknowledging some stressor or something going on, I make them sit down and think and come up with the imagery of another time when you had that same feeling, whether it was rejection or stigma or discrimination or pain or hurt or joy. And remember what happened with that story, because it's yours, and own it. And then we have that whole conversation, and we end with this affirmation. Your story is your power. Your power is your solution. Your solution is your salvation. And your salvation is your story. I want to thank you all for being with us today and this evening, sticking with us through it all. And thank you, Allison and Gloria Bachman, for putting it all together. Thank you all, and have a good night.